Hello everyone. Today I'm going to talk about renal diseases. I'll be talking about the renal diseases on these headings, that is introduction, kidney structure, vasculature, clinical manifestations of renal injury, structure of glomerulus, pathogenesis of renal injury, and mechanisms of glomerular injury which will lead to the reduced GFR and the basic renal disorders. Right? So, the infinite artfulness of the human body is that whether you take wine, whether you take milk, whatever you take, it will be turned into urine. The kidney has a capacity of turning or filtrating approximately about 1700 liters into a liter of urine. You know, such a tremendous capacity of the kidney to excrete, to eliminate the unwanted products and then purify or detoxify whatever unwanted things are there. So this is about the renal introduction. Then coming to just see, these are the two biopsies. This one is of the adult kidney biopsy and this one is of the infant kidney biopsy. Here you can see that the kidney is in reniform shape. Usually the kidney is having a smooth surface and then the capsule is attached to the surface. This is what you see in the adult kidney. But in the infant kidney, you see that there are these lobulations. So during the development, what happens is that these lobulations are fused together. If this does not happen, then what happens is that this will lead to some congenital abnormality of the disease. So coming to the kidney structure, this is the heavy section of the kidney, the gross biopsy. Then you can see here the cortex. These are the columns of Bertini, the renal pyramids, the sinus and the collecting system, cortical sinus or whatever. So this makes the renal pelvis, this is the medulla and this is the cortex. So these are the structures which are in proportion to each other normally. But if there is any disproportionate increase or if we are unable to distinguish the cortex and the medulla, or the corticomedullary junction is lost because of any disease, then by just seeing the gross, you can know that there is some disease involving the kidney. So the same thing represented here. Here you can see there is a renal artery, the renal vein, and then this is the pelvic junction, this is the renal pelvis. Right, and these are the minor calyces, major calyces, minor calyces, and the renal papillae. Here, the renal papillae are usually important because the collecting system ends obliquely or linearly on the renal papillae. Okay, and here this is the cortex and this is the medulla. So this is the capsule, the cortex and the medulla. So the cortex and the medulla should have a proportion. And if there is any disproportion regarding the cortex and medullary junctions, then we can know that there is some disease involving the kidney. Now coming to the vasculature. The vasculature, the renal artery arises from the aorta and then the right is a bit longer than the left renal artery. You know that the renal artery also gives rise to a branch which supplies the adrenal, right? So here the renal artery is divided into anterior branch and the posterior branch. These are again divided into 5 segmental arteries. These 5 segmental arteries are again divided into the interlobar artery. Again, they are divided into the arcuate artery and the interlobular artery. So all these arteries will kind of supply the whole of the renal system. Usually the cortex is very heavily supplied by blood, whereas the medulla, it is less supplied than the cortex. So whenever there is any obstruction, the medulla gets affected and then there is renal infarction. So here this is a renal vein again, you can see the branches supplying the whole of the kidney. So this is about the vasculature of the kidney. The functional part of the kidney is known as the nephron. The morphological parts of the kidney are the glomerulus, tubules, interstitium, and blood vessels. Okay, why are we dealing about all these things is that if we want to know about any renal pathology, you have to know about the anatomy and the physiology prior proceeding to the pathology. So here we have the glomerulus, which is usually the main important structure where the filtration happens, right? So because the glomerulus is such an important thing, usually the injury is related to the glomerulus is immune mediated. The tubules and the interstitium are usually affected by toxins or bacteria or virus, that is the inflammatory agents. Coming to the blood vessels, the flow of the blood is maintained in the kidney with certain pressure. If there is any abnormality in the blood pressure or the blood supply of the kidney, then it will get affected, and thus there is an injury that is happening that will lead to a renal pathology. So before I just get into the details of the renal pathology, a little bit about the tubular renal function. Okay, you already know about it. That is, the kidney has the tubules called the proximal convoluted tubule, the ascending limb, the loop of Henle, the descending limb, and then the distal convoluted tubule and the collecting duct, right? You already know about this. So what happens in the proximal convoluted tubule is that almost 50 to 55% of the sodium gets reabsorbed. Usually that is co-transported along with the sodium is the potassium, amino acids, phosphate, and then the glucose. Now there are some things which will reabsorb the water. These things or the specialized structures which are present in the proximal convoluted tubule are known as the aquaporins. And again, the hydrogen ion is exchanged for the sodium here, and then almost 80% of the bicarbonate is again reabsorbed in the proximal convoluted tubule. Now coming to the loop of Henle, the descending and the ascending. See here, the descending limb is usually permeable to water, and the ascending limb is usually permeable to ions. So here what happens is that the urine gets concentrated and the reabsorption, whatever which we require, is getting reabsorbed, right? So here we talk about the distal convoluted tubule. Usually in the distal convoluted tubule, the calcium, the important thing is that the calcium, whichever is present, is just occurring here, okay? And then the co-transport of the sodium and chloride also occurs in the distal convoluted tubule. Again here, then the distal convoluted tubule enters the collecting duct, wherein the collecting duct has two important cells, that is the principal cells and the intercalated cells. The intercalated cells help in the acid-base balance, and the principal cells usually are relatively permeable to water. That is, whenever there is secretion of aldosterone, then what happens is that the intracytoplasmic vesicles fuse together, and then they start forming the aquaporins, and then there is water reabsorption happening here. So this is about, in very brief, about the proximal convoluted tubule where maximum reabsorption happens, and then the descending and the ascending limbs, loop of Henle and the distal convoluted tubule, and the collecting duct with the principal cells and the intercalated cells. The collecting duct will usually open into the renal papillae either obliquely or linearly. Okay, whenever there is an oblique way of insertion into the renal papillae, what happens is that will function as a valve, and then whenever there is, see, for example, you're holding on to the bladder for a long, urine in the bladder for a long time, you didn't find a bathroom, then what happens? The bladder will then gets enlarged. So there can be a chance of reflux from the ureter to the kidney. So whenever this reflux happens, these oblique papillae which are there, oblique insertion will close like a valve and then will not enter the urine, which is reflects back into the kidney. So what happens is that you are preventing the reflexed urine into the kidney, so that you're protecting the kidney from any bacteria, virus, something like that, which are accumulated in the urine, right? So if there is a linear insertion, what happens is that the linear insertion will cause, it is not having any valve-like mechanism. So at that point, it will just go inside and then it may cause damage. So usually this collecting the principal cells and intercalated cells are usually, the placement is very important. I mean, the situation or the where they are placed. The principal cells are usually placed in the cortex in the inner medulla and the intercalated cells in the outer medulla. So this is just to recapitulate whatever I have said. This is the cortex, the medulla, the renal papillae, the renal pelvis, the pelvic ureter junction. So the reflex of the urine will be stopped by this papillae if they're obliquely inserted in the outer medulla, right? So the structure of the glomerulus. So after knowing about the tubules, in brief, we are going to now know about the structure of the glomerulus. The glomerulus has the glomerular basement membrane, the glomerular capillaries, visceral epithelial cells, parietal epithelial cells, and mesangial cells. We're talking about all these things. What is a glomerulus? Glomerulus is nothing but a tuft of the capillaries which are formed by the efferent arteriole, and then they are invested by two layers of the epithelium, that is the visceral epithelial layer and the parietal epithelial layer, and then the interspace which is present between these capillaries is being supported by the mesangial matrix and the mesangial cells. So I just kept a picture to depict something how the glomerulus looks like. So here you have, for suppose this thread resembles the afferent arteriole, and here you have a tuft of these capillaries or which are formed. So if you have something like this at the other end too, that is the efferent arteriole. So what do you have? You have a space where the glomerulus lies. So this space is called as a Bowman space. So what does these do? When these two things are bound by something, some cell, that cell is called the mesangial cell. When these threads are together bound, these cells are the mesangial cells, and something that holds them together is a mesangial matrix. So here we have the glomerular capillaries. What is the importance of the glomerular capillaries is that it has a fenestrated endothelium. You know that the capillaries or any blood vessel is lined by the endothelium. So here there are some little gaps between the endothelial layer. The cells are such placed so that the diameter or the length between each of the cell is 70 to 100 nanometer diameter. I mean space, not the diameter, the space. So here we have the space like 70 to 100 nanometers, which will have the slit in between the cell. This is called as the fenestrated endothelium. So that will allow some things to go inside, right? It is not allowing everything, but just some things to go inside. That is about the glomerular capillaries. Now, glomerular basement membrane. See, the glomerular basement membrane has a central electron dense layer, and then the outer and the inner electron lucent layers. Okay, that is the inner electron lucent layer and the outer electron lucent layer. So these, because of that structure of the glomerular basement membrane, it has the filtration efficiency. The filtration efficiency of the glomerular basement membrane is dependent on two things, that is charge and the size. The charge dependent filtration is because the glomerular basement membrane will not allow any anions to pass through it. Okay, so because of that, albumin, which is highly anionic, is not going to pass through the glomerular basement membrane normally unless and until there is an injury. Now, the second thing is the size dependent. That is, the filtration is dependent on the size. So whenever there is a very large macromolecule like the laminin or the fibronectin, all these macromolecules or the collagen, they are not going to go through the glomerular basement membrane. So that's how a part of the glomerulus, that is the glomerular basement membrane, will help in the filtration. Okay, and the glomerular capillaries, I told you, in the form of fenestrated epithelium. Another important point about the glomerular basement membrane is that it is made of some beautiful structure, that is, it is associated with the non-collagenous domain 1, which is very, very essential. You know, it is like the, when we are constructing a building, you know, you kind of dig down and then you put coconut or whatever, and then you start constructing the building. So in the same way, the non-collagenous domain 1 will be the, what you call in Telugu is like, it is like the punadi of the building. Okay. So for this glomerular basement membrane, the non-collagenous domain 1 acts as that punadi for that glomerular basement membrane. So this non-collagenous domain 1 will have the property to attach the other molecules. Okay, so because of this, what happens is there is a proper arrangement of the lineation of the cells or the structures in the glomerular basement membrane, thus helping in the filtration. So I'm talking about the non-collagenous domain 1 because this also acts as an antigen whenever there is an injury. Something like an antibody comes and acts against the non-collagenous domain 1 will lead to some disease or renal pathology like Goodpasture syndrome, right? So this is important for the understanding of the renal pathology. So we've talked about two things. That's the glomerular basement membrane, which filtrates because of its structure, the non-collagenous domain 1, which acts as a support, and then the charge-dependent filtration, the size-dependent filtration, and then the glomerular capillaries with the fenestrated endothelium. Now coming to the visceral epithelial cells. The visceral epithelial cells are otherwise known as the podocytes. These are very, 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 very important because they have a structure which is actually supporting the endothelium, the basement membrane, and then this tuft is invested in two layers. I told you, the visceral epithelial cells and the parietal epithelial cells. So the visceral epithelial cells or the podocytes, if they are injured, it will cause something called as podocytopathy. So because of that, what happens is that the filtration capacity or the GFR is usually diminished. That is, everything will just go by into the urine. So we will not be able to reabsorb what we require, and then or whatever we require also goes through the urine. So what happens is that there may not be an effective filtration. Because of that, there can be increase in the urea and creatinine in the body, which may cause ill effects to the body, right? So this is about the epithelial cells. Now coming to the mesangial cells. The mesangial cells act as pericytes or smooth muscle cells. I already told you the kind of support in between the capillaries, and then they form the mesangial matrix. These mesangial cells also have the phagocytic activity. They kind of produce the cytokines whenever they think that there is an antibody attacking the kidney or the glomerulus. They go there and then produce the inflammatory cells and then the cytokines, and then there can be recruitment of numerous leukocytes, and then there is deposition of these antigen antibody complexes, or there can be deposition of the extracellular matrix. So this is importance of the structure of glomerulus. Without a basic understanding of the anatomy, physiology, we cannot go into studying pathology, right? So here, I told you these are the visceral epithelial cells known as the podocytes. I told you there is the endothelium here, which is fenestrated. Okay, this is the slit. Okay, and then this is called the filtration slit here between the two podocytes. Here we have the basement membrane, the central dense layer, the inner and outer electron lucent layer. Here we have nephrin molecule. The nephrin molecule, the CD2AP, the podocin dactyl filaments will maintain the integrity of the structure of the glomerulus. Okay, they maintain the integrity because the nephrin molecules are extracellular. They are something like IgG, antibody like structure they have, and then here you can immunoglobulin like structure. That's what I mean. They're not the antibody, but they have immunoglobulin like structure. So these nephrin molecules are attached into the intracytoplasmic podocin with the help of CD2AP protein, and then these are again supported by the actin filaments. So what is the importance is that they maintain the integrity of the filtration slit and the podocytes. Okay, if these molecules are having any abnormality, that is, if there is a problem in the nephrin or the podocin or the actin filaments, there can be no proper integrity. So what happens? There will be podocytopathy, there can be loss of the podocytes, there can be effacement of the podocytes. So basically the filtration slit will not properly exist, and then there will be again deposition of unwanted material, and then the filtration will not happen as we require. So this is the importance of the podocytes. So here you have to know that, see, I told you that glomerulus is a tuft of the vessels which are invested by visceral epithelial cells and the parietal epithelial cells and situated in the Bowman's space. So here we see this is the afferent arteriole which begin to form. See, this is the cross section. You are taking the cross section of the tuft. So here you are seeing the afferent arteriole, and these are the capillaries. Okay, and then this is the efferent arteriole, and this is obviously lined by endothelium. And then here you are seeing these things are the visceral epithelial layer. Okay, these are the mesangial cells which are holding these capillaries together. So these are the mesangial cells. Okay, this is the mesangial matrix in between the mesangial cells. Okay, and this is the parietal epithelial cell. Okay, so this is the structure of the glomerulus. Again, just to tell you again what is what. Okay, so here we are having a renal artery. So how is it all? So there is the glomerulus, the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and the collecting tubule, right? So here we have something called as vasa recta, which are the plexus of the capillaries, which are trying to supply this part of the kidney, right? So this is the functional part of the kidney wherein you have the filtration occurring, right? So this is the renal artery, the renal vein. I already told you about the same. So here we have to understand the functional part of the kidney nephron is supported by the glomerulus, the tubules, the interstitium, and the blood vessels, right? So the GFR is basically maintained by autoregulation and tubulo-glomerular feedback. Whenever there is something which is not getting filtrated in the glomerulus, is usually filtrated by the tubules. And the neurohormonal influences. Whenever we talk about the neurohormonal influences, we should talk about the sympathetic system, the parasympathetic system, and also the hormonal influences like the renin, the parathyroid. All these things will have an effect on the glomerular filtration rate. So How is, just in brief about the regulation of glomerular filtration rate. See, the macula densa, you know that there are some cells called as juxtaglomerular cells and then the macula densa, right? So the macula densa is having a specialized function of knowing about the chloride concentration. So whenever there is a decrease in GFR, there is decreased chloride. So what happens? There is dilatation of afferent arteriole and constriction of efferent arteriole. And then there is renin secretion, increased hydrostatic pressure, and that's how it restores the glomerular filtration rate again back to the norm. Whenever there is decrease in the blood pressure, that's systemic arterial pressure, the juxtaglomerular cells secrete the renin. You know, the angiotensin gets converted to angiotensin 1 and then 2. And then there is also formation of aldosterone, and then construction of efferent arteriole, that's how the GFR is restored. So this is about the regulation. I told you the GFR is regulated by three mechanisms, that is autoregulation, the tubulo-glomerular feedback, and then the neurohumoral hormonal mechanisms. So coming to the functions of the kidney. The kidney, we know, is a major thing which is helping us in excretion of unwanted waste materials in the form of urine. If there is excessive waste accumulating in the body, that will form toxins and then cause various systemic effects. It regulates water electrolyte balance, because I told you the proximal convoluted tubule and all the tubules and the glomerulus help in the filtration, and then they reabsorb the water. Then the chloride, the sodium and the chloride act as co-transported in the distal convoluted tubule, and then we also spoke about the hydrogen bicarbonate exchange. Hydrogen sodium exchange in the proximal convoluted tubule, so that 80% of bicarbonate gets absorbed. That's how it regulates water electrolyte balance. We also talked about the co-transportation that occurs along with the sodium, with glucose, amino acids, phosphate, and all. So this is about the regulation of the water electrolyte balance. The acid-base balance is again the same about the bicarbonate and all, and the chloride. And endocrine mechanism, you know, we spoke about how the kidney helps in constriction of the efferent arteriole and vasodilatation of the afferent arteriole, and then production of renin, conversion of angiotensinogen 1, 2, and then, you know, formation of aldosterone, so that there is a proper balance. And vitamin D, you know that it is the formation of calcitriol happens in the kidney, that is 125 hydroxy cholecalciferol, you know, that happens in the kidney. It's because of that the mineralization of the bones happen, and then there is increased absorption of the calcium in the gut. So that's how there is an endocrine mechanism of the kidney also. Then it also regulates the blood pressure. Blood pressure is regulated by the kidney in form of maintaining the vascular pressure in the kidney, and then by renin. So what happens when we have a kidney problem? Usually, if there is an infection, whether in the urinary system, whether in kidney, ureter, urinary bladder, or any other place as such in the body, will cause fever. Then if there is any problem in the filtration, then that may cause infarction, and then there can be a stroke. If there is a fluid electrolyte imbalance, that will cause thirst and tiredness. It can cause chest pain if there is fluid retention, and also if there is any kind of abnormality in the fluid maintenance of the body. Then itching. Itching can happen if there is uremia. Obviously, whenever you do not want that product and that stays in your body, then it will cause itching. Tumors. The tumors, renal cell carcinoma can occur, and then the urinary bladder tumors that can have problems. Then stones. Whenever there is excessive or abnormal accumulation of the end products like the cysteine and the oxalates, these will cause stone formation. Then polycystic kidney disease that can have abnormal distension of the abdomen, and then there can be fluid accumulation, and there can be multiple cysts in the kidney on both sides or either one side. Then what happens is that there will be enlarged kidney. Tubular dysfunction. The tubular dysfunction can occur with lot of toxins accumulation, and then something like if you take some toxins, or if there is a tubular injury because of the bacteria or the virus, that can cause tubular dysfunction. And there can be swollen ankles, and there can be weight gain. The swollen ankles and the weight gain are usually because of the fluid accumulation. So basically, the kidney forms the excretory organs, so whatever gets retained will cause an effect on the body. So here we have the fluid electrolytes. If there is an imbalance in that, it will cause dehydration, edema, hyperkalemia, metabolic acidosis. Again, acid-base balance, it helps. So there is no proper bicarbonate in the body. And then calcium, phosphate, and bone, I told you it's vitamin D, formation, which helps in mineralization of the bone. If that doesn't happen, and the phosphate, if it's not excreted, it will cause hypophosphatemia, hypocalcemia, secondly hypoparathyroidism, and renal osteodystrophy. Hematologic. One most important thing is that in endocrine mechanisms, it also secretes erythropoietin. Erythropoietin is something which is very essential for the increased production of the red blood cells from the bone marrow. It's the stimulus. So if that stimulus is cut off because of any chronic kidney disease, then it will cause anemia and bleeding. Dialysis is another thing. In cardiopulmonary is congestive heart failure, cardiomyopathy, pulmonary edema, uremic pericarditis, hypertension. All these things can occur because of lack of proper function of the kidney. Gastrointestinal, there can be esophagitis, gastritis, colitis, bleeding, nausea, vomiting because of the chronic kidney disease. Neuromuscular, we have peripheral neuropathy because of uremia, encephalopathy, and myopathy. Dermatologic, sallow color, it has pruritus or itching, then dermatitis or inflammation of the dermis. So with understanding of what kidney is, we have talked until now about the structure of the kidney, the major functions of the kidney, what happens if the function is lost, and we also spoke about the various manifestations or clinical manifestations of the disease when we have a renal pathology. Now coming to normal terms, before we just go deeper into the subject, we have to know certain terms. That is oliguria. Oliguria is less than 400 ml of urine excretion in 24 hours. So that is very less urine excretion. This is something you have to just remember the term, that's less than 400. Polyuria, you're more excreting urine, you just sit for 5 minutes, then you want to go and pee, that's polyuria, usually seen in diabetes. Hematuria is seen as a result of infection, as a result of acute glomerulonephritis, as a result of stone, as a result of tumor. There can be various causes of hematuria. And whenever there is hematuria, you can see dysmorphic RBCs, which kind of distorted the shape, and then you can see all of those in the normal urine examination. So proteinuria. Proteinuria is termed only when there is more than 150 milligrams of protein leakage. Okay. And if this proteinuria is persistent, then we have to look for more renal pathologies. Anuria. Anuria is complete absence of urine formation. Okay, so these are the terms about the excretion of the amount of urine. Now coming to proteinuria. Proteinuria, I told you, more than 150 milligrams is the baseline, which is termed called as proteinuria. That's very, very slight. There is something called as microalbuminuria if it is more than 300 mg. And then the functional proteinuria, this is usually less than 2 grams per 24 hours. Okay, the functional proteinuria usually seen in fever. There is no proper renal pathology, but then there is some passive formation of, filtration of the protein. So this is called as functional proteinuria. Overflow proteinuria is seen in multiple myeloma. Okay, and there is because of excessive accumulation or excessive formation of the immunoglobulin light chains that are getting excreted in multiple myeloma. Then glomerular proteinuria, that can be two types, that is nephritic proteinuria or nephrotic range proteinuria. Nephritic range proteinuria means less than 3.5 grams, and proteinuria, I told you, should be more than 150 milligrams per 24 hours. So nephrotic range proteinuria is more than 3.5 grams per 24 hours. And then the tubular proteinuria is less than 2 grams per 24 hours. So in the nephrotic range of proteinuria, it is also associated with hypoalbuminuria, lipiduria, hyperlipidemia, and severe edema. So the nephrotic syndrome is defined by having a nephrotic range proteinuria that is more than 3.5 grams per 24 hours. Hypoalbuminemia, because you are giving all the protein out into the urine. Then hyperlipidemia, and then lipiduria, because the macromolecules are getting thrown out. Then severe edema because of the accumulation of the fluid. So this is about the proteinuria. You have to remember the nephrotic and nephritic range, if not the others. So coming to the symptoms and signs. So normally when the patient comes, what do you look for or what do you investigate for? There is something called as azotemia. Azotemia is defined by increased blood urea nitrogen and creatinine associated with decreased glomerular filtration rate. So why there is increased blood urea nitrogen creatinine is that obviously there is decreased GFR. Because there is decreased GFR, the urea and the creatinine, which has to be excreted in the urine, are being retained. Okay, so because of that there is uremia, and if there is uremia, increase in the urea, it can lead to systemic manifestations like gastroenteritis, uremic fibrinous pericarditis. Okay, the kidney diseases, because of the toxic end products are not being thrown out by the kidney, they are getting accumulated and then they are forming systemic manifestations like the gastroenteritis and the uremic fibrinous pericarditis. Now coming to the other one, that is a nephritic. The nephritic, usually the azotemia, that is the increased blood urea nitrogen creatinine, may be the result of prerenal causes. The prerenal causes may be the congestive heart failure or the decreased volume of the total volume of the blood, There are prerenal causes, okay. The renal causes are the nephritic syndrome. Nephritic syndrome, again, I told you, less than 3.5 grams per 24 hours protein should be eliminated. That is not in the range of nephrotic. And then it is characterized by hematuria, which are seen like dysmorphic RBC. You see red colored, smoky urine, then a decreased GFR, proteinuria, and hypertension. Now, there is rapid proliferative glomerular nephritis, that is decreased GFR, which happens just within hours. The patient comes to you, then you see that there is increase in urea and creatinine, and then you have this signs. So the nephrotic range, I told you, the hyperlipidemia, lipiduria, hyperproteinuria or proteinuria in the range of more than 3.5 gram per 24 hours, severe edema, and hypoalbuminemia. So these are the nephrotic syndrome constituents. Okay, these are the symptoms and the signs. Now, there can be some asymptomatic proteinuria or asymptomatic conditions where there are only a minor or subtle abnormalities in the glomerulus. Then the disease is not absolutely manifested. The patient just comes, for some other urine examination or something, and you find some abnormality. That is a symptomatic condition. Then something called as acute kidney injury, wherein there is decreased GFR, which occurs from hours to days. So the other important thing is chronic kidney disease. That is the glomerular filtration rate that is less than 60 ml per minute per 1.73 meter square, which is persistent for 3 months. Okay, the chronic kidney disease, any systemic primary glomerular injury or a secondary glomerular injury or the tubular injury can finally lead to the staging of the chronic kidney disease, wherein there is glomerulopathy, and then you calculate the GFR. If the GFR is less than 60 ml per minute per 1.73 meter square persistently for 3 months, then you call it as chronic kidney disease. So now coming to the other one called as end-stage renal disease. So when this chronic kidney disease, when you kind of stage it according to the GFR, if it is less than 5%, it will result in end-stage renal disease. Okay. Then coming to the renal tubular disease, it is characterized by the symptoms like nocturia, polyuria, and electrolyte disorders. The renal tubular diseases are usually associated with nephronophthisis and medullary cystic disease. Okay, so you have to know that if a patient comes to you with nocturia and polyuria and electrolyte disorders, the most common thing you think of is diabetes, and then after that, if you're still not having anything, you go and investigate, you find diseases like nephronophthisis and medullary cystic disease. Then the other one is urinary tract obstruction. The urinary tract obstruction can be caused by a stone or a tumor, which will eventually cause an infection, and it will cause a glomerulopathy if not taken care of. So whenever the patient is coming to you with some abnormality or you're thinking in terms of renal disease, you should be advising all of these investigations or some of this. So this is biochemistry. You have to do the urea, creatinine, electrolytes, and glucose. Hematology, you have to take a full blood count so that you will find the leukocytes. If they are increased, you will be thinking in terms of any infection. Then differentials is the same thing, about the WBC, whether neutrophils are more, whether lymphocytes are more, all these nucleus. The coagulation studies to know about the blood coagulability. Immunology or serology about the immunoglobulins, serum protein, immunoglobulins, because there can be certain diseases like systemic lupus erythematosus, which can be associated with the lupus nephritis. Immunoglobulins have helped in getting to the lupus nephritis. Now, serum protein electrophoresis, electrophoresis, urine electrophoresis, or serum protein electrophoresis in multiple myeloma, when you are thinking in terms of overflow proteinuria, autoantibody screening, like ANCA, anti-GBM. Anti-GBM, I told you, it's Pasteur's, anti-streptolysin O, C3C4, cryoglobulins, Benz-Jones protein, C-reactive protein. So this is about immunology and serology, and imaging, ultrasound, CT, MRI, nuclear medicine, angiography. So angiography, when you're thinking in terms of renal vessel stenosis, renal vessel infarction, and then ultrasound, CT, MRI, about the soft tissue, and if there are stones and all, the imaging is very, very essential. Urine analysis, the protein, red vessels, leukocytes, glucose, microscopic gas, crystals, and bacteria, nitrates, and culture. Culture, you advise when you're thinking in terms of infection, you do a complete urine examination, you find more leukocytes or WBC in the urine normal microscopy, the pus cells are found, then you order a culture, you get a result, then that's how you treat. Red blood cells are usually not found in the urine, but if you are finding them, then you must be thinking in terms of an injury to the kidney, or you have to know if it's the frank blood or you're seeing dysmorphic RBC. You should rule out acute glomerular nephritis, infection, tumor, and whichever will cause the red blood cells. The protein, the quantitative analysis of protein in terms of dipsticks, okay, or in terms of semi-quantitative, what kind of protein, whether it is an albumin, globulin, that kind of analysis you have to do. And then glucose, usually we correlate the serum glucose levels in the diabetes with the urine glucose levels. If the urine glucose levels are high without any increase, there's another condition called as renal glycosuria. I think you people know it. So the glucose, if you just have a dipstick, that dipsticks, now there are many dipsticks, just take a bottle of urine, then put a dipstick in that 30 milligrams is also, we can find the glucose, about 30 grams of glucose in the urine can be found by a chemical dipstick, 30 grams, as small as that. Microscopy for CAS are nothing but the homogeneous materials which are protein usually found in the kidney. Sometimes in some CAS like hyaline CAS, they're just there and they're not significant of anything. But if there are some certain CAS like RBC CAS or WBC CAS, that will point you towards some disease. Then coming to renal biopsy, light microscopy, immunohistology, and electron microscopy. See, the light microscopy will help you to know about the basic understanding. And the immunohistology, if you're throwing about some immunohistochemistry onto that, or immunofluorescence, then if it is granular and linear, and how the fluorescence is looking like. See, for example, anti-GTM disease. You have an antigen on the glomerular basement membrane, antibody goes, reacts there, and then there is a fluorescence produced. And because of this fluorescence, what happens is that the glomerular basement membrane shines, the color, whatever. So because of that, you know that there is an anti-GTM disease. So there is a linear pattern there. So here we know about the immunohistology. Then electron microscopy. Electron microscopy, you can see as well as the podocytes and all, the filtration, how it is, if there is any effacement of the podocyte, all these things can be observed. So after knowing about that, if we have to call for some renal function tests, blood urea nitrogen, I told you, the normal level you have to do is 7 to 18 milligrams per deciliter. Whenever there is an alteration in the blood urea nitrogen, that can be associated with a pre-renal cause, a renal cause, and a post-renal cause. In the pre-renal cause, if there is hypoperfusion of the kidneys, then what happens? The kidney is not getting enough of the fluid to filtrate. So there will be alteration in the blood urea nitrogen. If there is a problem in the kidney itself, that is a renal cause, like a glomerular nephritis or something, then the kidney is not able to filter it again. So the GFR is decreased. So again, post-renal cause, like a stone or a tumor that is obstructing the flow of the urine, will cause reduced GFR. Again, there is increase in the blood urea nitrogen. Okay. Then coming to the other one. So blood urea nitrogen is product of what? It is a product of amino acids, pyrimidine, and ammonia. Okay. So these end products of pyrimidine, ammonia, and amino acids, if that is not being filtered or excreted out, that will cause increase in the blood urea nitrogen. That can be of pre-renal cause, renal cause, post-renal cause. Now coming to the other one, that is a serum creatinine. You know that creatinine is the product of the creatine which is there in the muscle. So here we have the serum creatinine level, usually 0.6 to 1.2 milligrams per deciliter. But still, see, each and every lab, if you're using a different reagent, you have certain other values for it. It can be variable according to the lab, but then usually it is 0.6 to 1.2 or about 1.5 milligrams per deciliter. Okay, whenever there is problem in the excretion, there will be increase in the serum creatinine level. Okay, then coming to the other one is the ratio of the blood urea nitrogen and the creatinine. Usually it is 15. Okay, whenever there is an impairment of the same thing, the pre-renal cause or the renal cause or the post-renal cause, then the blood urea nitrogen and the creatinine ratio will be altered. Then coming to the creatinine clearance. Now, creatinine clearance is usually less than 100. Okay, if it is less than 10, that means that the patient is having very bad renal state. Okay, so the creatinine clearance is usually 97 to 137 ml per minute, and this we can say that after 50 years, usually 1 ml per minute is getting decreased after 50 years. That is a filtration rate or the clearance capacity of more than age 50 years people is getting reduced annually by 1 ml per minute. Okay, this creatinine clearance can be calculated by taking the urinary creatinine, the plasma creatinine, and because of that we get to know about the creatinine clearance rate. Okay, the blood urea nitrogen and creatinine ratio, how it is getting altered. See, in the normal person, you have something flowing in the blood. For example, it is 15 here. Okay, it is getting filtrated, and then it is again, the ratio is maintained finally about 15. Then what happens in pre-renal azotemia? When there is hyperperfusion and all, the reabsorption is certainly not happening as it is wanted. So what happens? The blood urea nitrogen and creatinine ratio is getting increased because of lack of proper reabsorption. Now coming to the renal azotemia. What happens in the renal azotemia? Because the kidney is not able to filtrate properly, there will be other ways of excretion, that is by skin and gastrointestinal tract. So what happens? The amount which is reaching the kidney itself is, the ratio itself reaching the kidney will be less, because it is finding other ways of excretion like skin. Okay, so because of that the ratio is generally decreased. Okay, so it is less than 15. In the post-renal azotemia, because of obstruction by stone or tumor or whatever, there is decreased GFR. And because of decreased GFR, the reabsorption is again not happening, and then the blood urea nitrogen creatinine ratio is now more than 15. So to tell you, in pre-renal azotemia and post-renal azotemia, the ratio is maintained more than 15 because of improper reabsorption. Here in the renal azotemia, the thing is finding another source of excretion like skin and gastrointestinal tract, and the ratio is which is reaching the kidney will be less, and then it is the same, that is less than 15, that is maintained in the urine. So coming to the urine analysis, we have a general examination. Whenever you ask a person to collect a urine, you give a container, the person will you will see the color of the urine. Then if it is dark yellow, you may think of jaundice. If it is pink, you may think of hemoglobinuria. If it is smoky, you think of some acute glomerular nephritis. If it is black, non-standing cases of alkaptonuria, it will turn black. Now coming to the other thing which you have to see is for clarity. If it is cloudy, you will think of some phosphates and all. Specific gravity. Specific gravity is usually representative of the osmolality. Say if the specific gravity is fixed, like 1.010 in chronic kidney disease, it's not getting affected, then it is a renal pathology. Now coming to the chemical property, dipsticks. I told you The proteins 1.5 to 8 is also sensitive, and glucose 30 grams of glucose present in the urine is also being measured, 30 milligrams. The ketones usually which are present in the urine are sensitive to the chemical dipsticks are the acetone and the esteoesteric acid and not the beta hydroxybutyric acid. Okay, remember that. The pH, usually the pH is important whether it is acidic urine or whether the alkaline urine, because sometimes the triple phosphates occur in the alkaline urine. Coming to the other one is bilirubin. Usually the conjugated bilirubin is only present and not the unconjugated. Urobilinogen, if it is present more, we will think in terms of some hemolytic process. Then coming to the blood, you can just find blood just by looking at it, Then nitrates, then glucoside esterase. So these things can be seen by the dipsticks. We can have the chemical properties. Now coming to the sediment, urine is collected in the container in the form of the container, then you will kind of centrifuge it, When you centrifuge it, what happens is that all the cells will get collected at one place. When you filter those cells and look under the microscope, you can see these cells. That is either the bacteria, usually they are not present. You are seeing a bacteria, you know that there is an infection, you order for a culture, you can see a fungus. The dysmorphic RBCs, you can see an acute glomerulonephritis and hematuria. Hyalin cas, I told you, amorphous eosinophilic material, which is the resultant of the protein that is present in the kidney. RBC cas, WBC cas, fatty cas, renal tubular cell cas. Okay. Then crystals, the calcium oxalates, usually the vegan diet will have calcium oxalate crystals, uric acid, gout, triple phosphate crystals, usually in the alkaline urine, they form triple phosphate crystals, and cystinuria. So we are talking about the urine analysis now, because when a patient comes to you, before I start to tell you about each and every part like glomerular, tubular diseases and all of that, when a patient comes to you or when you are looking at a disease of the kidney, you have to know all these things. Okay, you have to know what kind of injury will lead to what kind of pathology and how do you write the question in the exam. You kind of write any glomerular injury in terms of the systemic manifestation, the signs and symptoms associated with the investigations you ask for, the urine analysis, the ultrasound, how it looks like, MRI or the imaging, how it looks like. Then you will ask for a biopsy and how the biopsy looks like under the light microscope, under some special stain, under the immunofluorescence. So this is a brief introduction about all of this. Okay, so what investigations you ask a patient is important, because whenever you are writing just an answer in the exam, whenever you are thinking, looking at a clinical question related to kidney, you will not have any confusion if you look at each disease of the kidney in terms of this. Okay, so this is about the brief introduction about the kidney and the kidney diseases. We spoke in brief about what the anatomy, the vasculature, the functional aspect of the kidney in terms of glomerulus, tubules. Then we spoke about the glomerulus in detail. And then we spoke about the investigation, the clinical manifestations, and the urine analysis. So this is it for today. And in tomorrow class, I will go in detail about only the glomerular disease, the pathogenesis of the glomerular injury. And if you just understand the structure of the kidney, it's just as beautiful as a painting, I tell you. Right? Okay. Thank you. Thank you for hearing me. See you tomorrow.